Based on Sarah's history and really the biopsychosocial assessment that was reviewed earlier in the presentation, we decided that in the part of trauma treatment that we explored was the EMDR processing module. And in generally, the assessment would start with a history screening. Now, EMDR is it means eye movement desensitization and reprocessing. Dr. Francine Shapiro is the originator of EMDR therapy. Sometime in 1987, she noticed her eyes were moving in a diagonal direction while she was just walking, reflecting on disturbing thoughts about her life. And being the exploratory person that she is, she started to really dig into why was that and why did that occur. It led to her to also explore this bilateral stimulation. And later on, if you get the time, just click on the YouTube link. It really gives an example and it shows a therapist actually implementing the bilateral stimulation methods. I thought it was pretty interesting. But for Sarah, a treatment plan will consist of essentially two parts. One, we will really explore her PTSD symptoms under the EMDR structure. There's a protocol that's called Detour Protocol, and really we would focus with her on creating a visual representation of life without active addiction. So we will really look at her alcoholism and really have her explore her life and what it would look like if she did not have the need or feel that alcohol, the role that alcohol plays in her life. We would also create a trigger list. This is something that is really important because we want to make sure that she makes a list of triggers for relapse, because as we work through all of her history at such a young age, and even triggers that she may have as she continues school and is introduced into adulthood, we want to make sure that she recognizes her triggers for relapse. And let's break it down. One of the triggers may just be that she has a male teacher that reminds her of some of the experiences that she's been through. So we want to make sure that we're going through it and processing that with her. Through the bilateral stimulation, we will start to desensitize her to those triggers and hopefully prevent relapse. I think based on her history and all that she's been through, we should really go through about 12 sessions, 90 minutes. In general, you would start with about 20 passes through the EMDR process, and then based on her response, we would really continue to move through and see if she can tolerate more or less. I would assume, just based on her temperament or her patience, we may have to play around with the time frame a bit. There's 8 phases of EMDR. One is the client history. You want to know what the client's history is because it really tells you how to proceed with the processes and proceed with the treatment as a whole. Then we want to go through and prepare. You want to know, do you have an appropriate relationship with the client? Have they been educated on what EMDR therapy really involves and introduced to the whole process? After that, you want to start to help the client to create a visualization of the image or the target. So it may be Sarah's mother, or one of the men in her life, or somebody that she was left with, and we start to work through the emotions. Is she feeling anger, guilt, grief, frustration, fear? And then you would start to reprocess the image, and work through the image, and the negative cognition of it, and you really want to locate any negative physical sensations, because your body tends to react one way or another when you're put into those particular circumstances. And then installation, and you want to make sure that through steps 1 through 4, phases 1 through 4, that it really was installed in the client's mind. So if it's with Sarah and it's a trigger or a fear factor for her to go to school, and that's why she drinks, so she can just kind of get through the day numb, or a little bit less anxious. So we want to go through and process the image of school, and then how can she pair that with a positive experience or a positive cognition. And then you want to do a body scan as far as how are you feeling, what is she going through, and how her body feels as she's processing through that. The next phase is closure. And then there's a revelation where they realize that, okay, school is not a trigger, and it's not going to harm me. It's just, and I can equate it to a positive experience. So, methods of evaluation. For this, we want to make sure that, we're looking at recidivism. Is she going back to using alcohol? Is she establishing healthy relationships with individuals? And how does she look at love and relationships? Is she having anxiety or stress when she's put in certain circumstances? Because we want to try our best to alleviate that. Is she having flashbacks? Is she feeling any kind of sense of anxiety when she's in particular situations? Is she sleeping well? So all of this, if we see improvement in these areas, it would really help us to be able to determine if she's really getting through the EMDR processes the way that we would hope. I added a quote: "It's all knowing what to start with. If you start in the right place and follow all the steps, you will get to the right end." This is by Elizabeth Moon. It was in one of the EMDR books, and I thought it was significant because really, with EMDR, what I've learned, and we've learned through this process, is that you really have to start at the right place and follow the steps. There's a particular training and expectation that goes with it. And if not, you can really reframe the brain to focus on the wrong things. And it can kind of bring up a lot of trauma. It can bring up a lot of trauma in people. So the individual strengths and weaknesses of EMDR are as follows. The strength is that the therapist must be licensed and have a master's degree to complete the training. Now that could be something that's considered a weakness, because it means that it's a significant amount of time that needs to be invested prior to a person implementing it. But I think from the client standpoint, it's a positive thing, and it's a strength, because whoever is working with you is well trained and experienced and skilled with not only with clinical therapy and recognizing signs and symptoms of mental health trauma, but also can help to work with the patient in a healthy way. It also has a 77% success rate, which is really good. I read a few things. Some of them said 90 and 80, but the reason why I used the 77% is because it was particular to trauma, PTSD, and some of the underlying effects of it with patients, particularly around some of the trauma. They talked about like if it's sexual trauma or if it's just like a one particular life experience, if it happened early in age. And I thought all of that pretty much affected Sarah. Also, from what I've read, many therapists are surprised at how fast it works, and with patients who have PTSD, that they see a pretty fast turnaround. And it really doesn't cost anything to implement initially. The only possible cost that it may be is the using tappers, which sometimes therapists have to use to really help to center the physical response for patients. Another strength is that there's alternative options. And by that, I mean that there's options that the therapist can take based on individualized patient needs, such as using the tappers or really adding or slowing down or speeding up the treatment to best serve the patient. The weaknesses are it varies depending on the onset of it and a pattern of complex PTSD. So if you're doing it with a patient and they're working through this experience, and then say Sarah goes to school and experiences sexual abuse. So now she's associating school with trauma, and she may not disclose that. So there's also, some factors that may not be controllable unless it's occurring in like a more controlled environment, like an inpatient setting. It can also trigger psychosis. In the readings, there were case studies of patients who went home and experienced such extreme trauma and flashbacks initially that it kind of brought up some dust. It's like kicking up some dust and then not being able to really clean it up till a little bit later. So it needs to be done in a strategic, timely manner. Therapy can also trigger some emotional distress and discomfort, and these emotions could also push a patient to not return or to actually relapse. Individual prognosis. EMDR should reduce relapse ratio for Sarah. It should reduce some of her PTSD symptoms. It should also motivate her. It should desensitize her to the triggers for alcohol use, and it should reduce symptoms of disassociation. A summary of some of the evidence-based practice readings that was reviewed. One was called Treating Addictions with EMDR Therapy and Stages of Change by Nancy Abel. In this book, Abel and O'Brien really addressed the problems in relation to addiction treatment, and it considers the relationship between addiction and trauma. This is really relevant to Sarah because she not only had alcoholism, it was associated with her trauma. She was so young and she was, trying to numb herself through her experience. Also, the second book was by James Knight, and it really used his experience to provide framework. He had about 20 years experience, and he really it's like a toolkit for the builders of EMDR, and you could really use the tools to make it fit in your particular patient or client needs. Thank you.